In patients with sacral dysmorphism, one option to gain access and control of the posterior pelvic ring is to use a CurvaFix in the upper sacral segment. Oftentimes, the upper sacral segment in a dysmorphic pelvis does not accept a linear screw. That's because of the dysmorphism and the narrow corridors in the posterior pelvic ring. And an S2 screw can be linear or straight, as the S2 corridor is larger and often more accepting of a straight screw. However, if you're doing a screw in S1 and need bilateral control of the posterior pelvic ring, and you want to use a straight linear screw, you're oftentimes having to go bilateral with one screw on one side and then rearranging the operating room by moving the fluoroscopy to the opposite side and yourself to the unoperated side to put that second screw in. By using a CurvaFix, you can use a single implant to gain control of both the right and left sides of the upper sacral segment and the posterior pelvic ring. For a sacral dysmorphic pelvis, a CurvaFix allows for transsacral and transiliac control of the posterior pelvic ring with a single implant. When we start a case like this, the most important thing, or one of the most important things, is getting good fluoroscopic images of the posterior pelvic ring to optimize implant application and to prevent screw migration or penetration into an area that would cause an iatrogenic injury. We start with either an inlet or outlet view. Can we roll to the outlet view, please? The outlet view is typically around 30 degrees, but as you get your imaging, what you want to see is nice round tunnels at S1, and typically the symphysis lives at S2. And in this case, on this fluoroscopic image, we can see the S1 tunnels. They are not perfectly round because you would not expect that in a dysmorphic posterior pelvic ring. The S1 tunnels tend to be oblong or oval as opposed to round. You can also see the lateral border of the S1 tunnel as a landmark that we'll come back to in a little bit. Once I have my outlet view, I'll take a marking pen and mark the plane of the C-arm on that view. So this is the plane of the C-arm. We know that this direction is cranial. I'll write that down. And this direction down here is caudal. Okay. Now, it's typically approximately a 60-degree arc from the direction that you're at to the opposite view. So currently I'm in an outlet view, and we're at how many degrees right now?
We're at 35.
35. So we should be somewhere in the 25-degree range past neutral on the inlet view. So we'll swing up to an inlet. When you get your inlet view, you want overlap of your sacral ala and a nice, clean, crisp image. And you'll see here that we have nice overlap of our sacral ala, and that's a nice inlet view of the posterior pelvic ring. I'll draw a second line that matches the plane of the C-arm to help me navigate when I want to move my starting wire. And so this is going to be anterior, and this will be posterior. And as long as I move in line with these marks on the skin, I'll always be orthogonal to my pelvis. Okay. At this point, we're ready to make a start point. The start point for a posterior segment screw is typically in the posterior superior quadrant of the pelvis. You can drop a mark from the ASIS and a mark in line with the femoral shaft, and that posterior superior quadrant is approximately where we'll be making your initial wire. Usually I'll use a 1.6 millimeter Kirschner wire to get into at least the geography that I want to be, the anatomy I want to be, before I put a larger wire in. But you can start with a large wire as well. So I'm going to go ahead and percutaneously insert this wire down to the bone, shoot that. And you'll see how posterior I am there. And so I'm going to bring my entire start point much more anterior. So I'll come out of the skin, and I'll translate my hand anterior, and I'll push in again. And that's a good starting point. It's a little bit posterior. And so I'm going to come up, I'm going to go a little bit more anterior again. Shoot that. And that will work. I'm not going to breach the anterior cortex. And again, for a CurvaFix screw, we don't have to have a perfect starting point. In fact, we want our starting point to be a little bit atypical so that when we drill at an angle and we can use the flexibility of the screw to our advantage. We want the screw to bend because the more it bends, the more points of contact we have. Can we go to the other view now, please? All right, so I'm too high here, so I'm going to start a little bit more caudal. Shoot that. Now that might be too caudal. It is clearly, but if I angle my hand a little bit or change my position, I can shoot that a little bit better. And I can start there and I can angle my starting point, again, because I don't need a perfect starting point for a transsacral transiliac screw if I use the CurvaFix device. So here I'll take a mallet and tap this into place. In good bone, sometimes you'll have to drill this in. And I will take the drill because this is reasonable bone. Now I'll just get this started a little bit. Great. Now that I have my starting point, I'm going to make a small incision here that will accept the steerable guide, please. The sharp steerable guide. So there is a tool on this that allows you to, and the sharp one as well. Thank you. That allows you to redirect if need be. So this is a sharp trocar. It can go over the wire. You can also lead with this if you want, but this can give you some control and clear off the soft tissue. Go ahead and shoot that. And I can redirect a little bit and control that, shoot that. I like that a lot. I'll take the wire driver. Can we go to the other view, please? I'm really too anterior there, right? So I need to take this whole thing and move it. I'm going to give that back to you. And I need to go more posterior. And so I'm going to bring my hand this way. Shoot that. That's better. Good. I like that. Shoot that. Great. I'll take, and I'm going to aim a little bit posterior. Shoot that. Great. I'll take the other view, please. That looks really good. And on that view, I need to aim a little bit posterior. And on this view, I need to aim a little bit cranial. Okay, good. Good. Shoot that. Good. I like that starting point. I want to change my angle a little bit, but I'm going to do that by introducing the triple sleeve. The triple sleeve allows us to manipulate the wire, place our drill, and place our instrumentation. And so we have a wire sleeve that'll go inside. It'll give us some control here, and I can then manipulate that. Great. Take the knife, please. I'll make this incision a little bit bigger. Thank you. There you go. Great. All right. Shoot that. Good, I like that. I'll take the wire driver to me now, please. So now I'm going to optimize my wire position so that I can get my drill in. I'm going to change my angle a little bit. Shoot that. Shoot that. I like that angle. Other view, please. I'm going to miss my S1 tunnel there on the outlet view, and now I just need to make sure that I'm good on my inlet view. And you'll see that if this was a transsacral transiliac screw that was straight, there's no way that I could get it across going in at that angle. And I like my start point there. And I'm not heading posterior. So I'm going to go ahead in, a little deeper, shot. That's great. Other view, please. So now that I've got my starting point, one of the advantages of this system is I can actually pin my guide in place so that I don't have to hold it with my hand, and I'll maintain my position throughout the duration of the case. So if I'm satisfied with this on this view, which I am, I'm just going to go ahead and lock everything down.
Take the wire guide out.
Yep. I'll take this out. I'll take a centering. Do you have the centering?
That's good. I don't want to put you back high enough, though.
Great. Great. I'll take another wire, please. And two pins go through this guide to hold it in place. Get in there. There we go. Great. Great. So now my guide is held in place, and I can now use both hands to do the rest of the procedure. With my wire in place, I'm going to go ahead and use the opening drill bit. The opening drill bit is 8.5 millimeters. This opening drill bit is really important because the body of the screw is fixed. there's a notch in this drill that you can see on the fluoroscopic image. And the drill has to be inserted to this notch. And you say, why do we need to do that? Because when you look at the body of the screw, the proximal body is rigid. So that distance matches the notch on the drill. This part of the screw is not flexible. So you have to have that much of an entry point so that it can accept the body of the proximal body of the screw. Think of this no different as the opening reamer for an intramedullary nail. The opening reamer is typically larger than whatever nail you're putting in, and as a result, you have to ream to that size and that distance to accept the proximal body of the nail. So I'm going to go ahead and insert the 8.5 millimeter drill bit and drill to that mark. Shot. Okay, other view, please. And you can see that I'm going to avoid my tunnel on that view. As we switch over to the inlet view, we should see that mark hopefully pretty clearly. Great, and so shoot that. Okay, and you can see the notch, shoot that right there. You'll see the notch, and I know that my guide is down to bone, and the fact that I can see my notch on that fluoroscopic image on this inlet view means that I am deep enough to be able to accept the proximal body of the nail. So now I'm going to go ahead and remove my drill. My guide wire will come with it. And now it's time to insert my guide into the tunnel I've created to help guide my ball tip guide wire. Shoot that. And now you can see that my guide is seated. And through this guide now I'll insert the ball tip guide wire. The ball tip guide wire has a bend on it already to help me guide myself across the posterior pelvic ring. So you'll see the tip of this wire is already bent. It's got a sharp trocar. It is flexible, allowing for passage through the corridors. Go ahead and pass that in. I'll take a T-handle chuck, please. So the T-handle chuck allows for malleting on the back of it. It's got a flat platform and allows for control of the ball tip guide wire and directionality. The other thing about the T-handle chuck is that it'll auto center the ball tip guide wire so that you're not eccentric when you load it. Shoot that. So on this view, if I were to keep going, I would violate the anterior aspect of the sacrum. So I'm going to turn this 180 degrees, shoot that, and now it's a little bit safer. So now I have to navigate around my dysmorphic pelvis, and I know that I've got to get around my tunnels that you'll see on the fluoroscopic images here, and I know that my corridor is not straight. And so there I am. I'm already around my S1 tunnel there. I'm going to stop there. For the purists in the room, we can obtain a lateral image of the pelvis to see that I'm actually anterior to the iliocortical density. So we're going to go ahead and do that. I don't usually do this when I'm using a CurvaFix, but I think it's important if you've not done this before or you have concerns that you get a lateral image before you go past the lateral border of the S1 tunnel to assess the position of your wire and make sure that it is anterior to your posterior iliocortical density and anterior to your S1 tunnel. So if you can go ahead and come to a lateral. You can see the iliocortical density on this view. It's very clear. It's that dark line. You can see that my wire is posterior to the iliocortical density on this lateral view, and I can make out the border of the S1 tunnel. And so my wire is anterior to the S1 tunnel and posterior to the iliocortical density. And so I know that at least on this side of the pelvis, this wire is safe. You can go back to the inlet or outlet view. Thank you. All right, so now it's time to pass this wire past my S1 tunnel on the near side and get it across past the S1 tunnel on the far side. So you can see there, I'm around my S1 tunnel there. Shoot that. Great. I don't want to go too caudal because I don't want to be able to not be able to get back over the tunnel on the far side. Shoot that. So I'm going to aim up a little bit. Shot. Great. I'm going to neutralize this side. Shoot that. Great. Shot. Can you go to the other view, please? Sure. Just make sure I'm not going too anterior. I'm safe there. I haven't breached. Shoot that. Okay. Other view, please. So now I'm at the midpoint of the sacrum. I want to make sure that I'm not heading into the tunnel on the far side on my outlet view. And you can see on my inlet view, I'm very safe here. Great. And you can see that I'm going to miss my tunnel on that side by aiming cranial. Shoot that. And now that I'm past my tunnel over there, I can rotate this so I'm not going too cranial. Shoot that. And come back around Oh, that's my tunnel. You can see it there. Shoot that, so I need to aim up. Great, I'm gonna keep going past my tunnel. Shot. And you can see it deflect off the tunnel. Now I can rotate, shoot that. That's nice and safe. It's around my S1 tunnel. Right, so now I'm at that far SI joint. I'm gonna make sure that my wire is safe. And it is. I'm above my tunnel there, so that's a nice safe screw. I'm gonna tap this into the far side. Shot. And in osteoporotic bone, typically you can get across the SI joint. Can you come to an AP with a 20-degree rollback, please? This view is really important to be able to see the lateral aspect of the far side of the pelvis to make sure that your wire doesn't breach that. So you can see we're right at that SI joint. I want to get into the iliac wing on the far side, and I want to make sure my screw goes all the way across that iliac wing so I get fixation in a transsacral, transiliac fashion in that good iliac bone. And so I'm going to tap my wire across the SI. Shot. And you'll see now I'm sort of docked there. I'm going to rotate the wire so it's going to go backwards. Shoot that. Great. I'm going to try and get it across the lateral wall. Shot. And you can see that I'm about to dock that against that good cortical bone. And I just breached a little bit, and people sometimes get worried that they breached, but here I measure to the ball tip guide wire, and I want my screw tip to be out the far side just a little bit. So I pull my ball tip back just enough, shoot that I can get an accurate measurement of the screw length I'm going to put in. So I'm going to remove the inner cannula that's been helping me control my pelvis. To measure the screw, the tip of the ruler has to go inside the hole that was drilled, and the top of the ruler mimics the top of the screw head. And there's a black line on the guide. That black line tells you where you need to be, and so this screw measures a 156. Our options are 150 and 160. In this scenario, I want to make sure that my screw threads are engaged and past that lateral cortex, and so I'm going to go for a 160 screw here in the back of the pelvis. In this case, I would go with the 9.5 millimeter screw because I have a large area that I can seat the screw in. You have the option of either a 7.5 or a 9.5. Usually in the posterior pelvic ring, I'll use a 9.5, but you can also use a 7.5 depending on what the CT scan looks like and how much room you have. Here you see a reamer. This is a flexible reamer over this ball tip guide wire. And it's a 7.0 end cutting reamer. One of the things that I think is important, in this case, I'm going to ream all the way down to that ball tip because I want to get through the far lateral wall of my iliac wing. And so I'm going to go ahead and turn this on, shoot that, and you'll see my curved implant, shoot that. Yep, pull back towards you. Just hear me going through the SI joint. And the far lateral wall is right there. And I just popped through. So now I'm going to hold this in place and remove my reamer. And now the reamer is out. And I'll make sure I don't lose my ball tip. There is an obturator for this if you would like to use that. I'm going to give the drill back. And now I'm going to exchange this with an exchange tube so that I can then place my screw. And I know for some of the older folks in the room, they would probably remember exchange tubes. I'm dating myself because we used to use these to put in good old-fashioned intramedullary femoral and tibial nails. But for the younger folks, they're probably unfamiliar with this step. The ball tip comes out, a smooth wire goes in. You can take a fluoro shot there. You can see the exchange tube through the posterior pelvic ring, and you want to make sure that you get that fluoro shot before you start the exchange process, because if the exchange tube is all the way down, then this is all for naught. I put my wire in, take a shot there, make sure that my wire is across, and it is, and I pull my exchange tube out. Great, I'll take the screw next, please. And again, everything works through the cannula here, so I'm able to put this screw in through the cannula. So with this system, especially the new version, there are two washer options. You have a larger washer if you're looking for more compression, or a smaller washer which will generate less compression because of the smaller surface area. The washers, I think, are important to get you a little bit of a squeeze, a little bit of compression across the back of the pelvic ring if you need it. In this case, I'll use the smaller washer. So now if I want to use the washer, I have to take the guide off. So I'll slide this guide right off. I'll leave my wire in place. I'll take the screw, I'll put it on the washer. I'm just going to follow the path of the wire. And you can see the screw is bending around the wire, which is great. Shoot that. And you can see I'm going to miss my tunnel on the far side. And now can you go to an AP with a 20-degree rollover towards me. So this allows us to see the seating of our screw. Great, and you can see now that lateral cortex that I want to seat my screw onto. You can also see the body of that part that we reamed. Shoot that. And now my screw is seated. You can see the washer is flat and it doesn't move anymore. It is a good, strong bite. Now, I'm going to lock my nail, so I'm going to remove the wire. I'm going to take the T-handle off. I'm going to place the tensioning device into the system here. And then there's a red and there's a green. So I'm going to hold this constant and I'm just going to turn this knob until it is green. There's a palpable feel to this when you lock it. And now the screw is locked and rigidly in place. I can now remove this, take these wires out, and then I need to these wires out of the way. And can you give me an inlet or outlet view, please? Sure. Thank you. And then I can remove the tool by countering myself and unscrewing this from the nail, from the screw. No different than an intramedullary nail. And oftentimes you'll catch me saying nail rather than screw because the steps are very, very similar. And so our final product, you can see that curvilinear screw in the posterior pelvic ring. There you go, shoot that. You can see it curving across the back, and then give me an inlet view, please. You can see that screw crossing the back and seeing the curvature of the back as well. And now give me an AP pelvis, please. And so for a dysmorphic pelvic ring, I find the CurvaFix to be a very powerful tool, one that allows me to do a single-sided screw, which historically I would have done through two separate screws, two separate positionings, repositioning of the room. I find it to be a time saver. I find having one single element in the back of the pelvic ring is a powerful tool to have, and you can see nice and safe here on this fluoroscopic image.